Hello, I'm going to ask everybody to find their seats so we can get started with the next presenter. Okay. Wait just a few seconds here. Okay. I'd now like to welcome Dr. Martin Cheatle, coming to us live from Ireland. I'm going to shout out and say, hi, Marty. It has been forever. I wish I could see you in person today.
Hey, Aaron, how are you?
Dr. Cheatle is an associate professor of psychiatry, anesthesiology, and critical care. He's director of behavioral medicine at the Penn Pain Medicine Center and director of pain and chemical dependency research at the Center for Studies of Addiction, Perelman School of Medicine at the University of Pennsylvania. He has been conducting research and providing clinical treatment of patients with chronic pain and comorbid disorders, including substance use disorders, HIV, mood disorders, and sleep disorders, as director of both university and community-based interdisciplinary pain programs. Currently, he serves as an ad hoc reviewer for the NIH HEAL initiatives and AHQR grants as an expert in pain research and clinical trials. And I would say that his presentation is very timely, coming off of the older adults presentation where we saw that chronic pain was very much an issue. Welcome, Dr. Cheatle.
Thank you so much, Aaron, for inviting me. Karen's like a second home to me. And you know, the more titles you have, the less money you make. So this is kind of a tough subject for some people, this whole area of suicide. So I would suggest if this is a particular trigger for someone, that they probably should sign off and not be really attend this talk. And I got interested in this whole area. Most of my research has been around pain and substance use disorders. At one point, I was directing the pain and substance abuse program at Karen about many decades ago. And I really got kind of struck by this. We were really so focused on the opioid epidemic, the crisis, that I felt we really missed this sort of underlying, disorder, the suicidal thoughts, the suicidal ideation of patients that are so vulnerable. So I really kind of shifted my work from just pain and substance use disorders to pain, substance abuse disorders, and suicide, which is why I'm never invited to parties, but I can be fun. And I just, in all seriousness, I really felt that these patients were just not heard. We were so obsessed with opiates are good and opiates are bad, that this was a silent epidemic that we really needed to have a voice to it. So let's see if I can advance this. There we go. So I have no conflict of interest, which is why I drive an old car, and this is my funding sources. So we're going to try to cover today in the next 50 minutes is sort of an overview of the area of pain, substance use disorders, and suicide, the risk factors, mediators, risk mitigation, and assessment interventions, both pharmacologic and non-pharmacologic, and then summary and future directions. As I start talking about patients with pain and patients with substance use disorders, you're going to see that there's a lot of crossover in terms of the risk for death by suicide. So if you look at global statistics on suicide, this is the World Health Organization 2019 report. So more than 700,000 people die due to suicide every year. Every 40 seconds, someone in the world dies of suicide. For the last few minutes that I've been talking, how many people have died by suicide? And for every suicide, there are many more people who consider it, who attempt it, who think about it. And a prior suicide attempt is the best predictor of a future suicide attempt. 77% of global suicides occur in low and middle income countries, again, not having the resources, and experiencing conflict, disaster, violence, abuse. And I'm putting in red loss, sense of isolation, which is very common with people with pain and also patients with substance use disorders, vulnerable groups who experience discrimination. I mean, still in our country, we discriminate against people who have a substance use disorder, right? We discriminate against people who have mental health disorders. So many of these factors come together in both patient populations to really increase the risk of death by suicide. So I was really struck by this particular figure from the World Health Organization. So of the 1.5 million violent deaths, now think about all the world wars that are going on. over 54% were death by suicide. And I thought that was striking. And this just underscores that it's the low and middle income folks that are at the highest risk. They don't have the resources. They're dealing with discrimination, social determinants of health, right? And so these, again, are the most vulnerable people. This is from the CDC. So for every 4 hospitalizations for suicide attempts, there's 8 emergency department visits related to suicide, 27 self-reported suicide attempts, and 275 people who seriously consider death by suicide. This is a preventable disease. You know, if we understand the risk factors, we understand the isolation, we understand the discrimination, and we battle this, we can change this tide in terms of death by suicide. So let's kind of drill back and look at chronic pain, substance use disorders, and suicide from an epidemiological perspective. There's a robust literature that patients that suffer from chronic pain are high risk for having suicidal ideation, anywhere up to 50%. A systematic review by Nicole Tang, who's a colleague of mine in the UK, and Crane revealed that the risk of successful suicide was doubled in patients with chronic pain as compared to the non-pain controls. Suicidal ideation in patients with substance use disorder. Approximately 40% of patients seeking treatment for substance use disorders report a history of suicide attempts. Some methadone clinics, if you say, I've tried suicide in the past, they will not enter you into treatment, which I think is egregious. Compare the general population. If you have an alcohol use disorder, you're 10 times more likely to die by suicide. If you have injection use disorder, you're 14 times more likely to die by suicide. Now let's put this in perspective. What is the percentage of people who actually literally die by suicide in this country? It's 1%. So look at that 1% compared to this high prevalence of death by suicide in these vulnerable populations. This is a study looking at 60 adults receiving inpatient detoxification and stabilization, who reported a history of opioid overdose, completed questions about their suicidal thoughts prior to their most recent overdose. Desire to die was common in adults with opioid use disorder prior to a non-fatal opioid overdose death. And 1 in 5 people with a history of opioid overdose reported an intent to die. So a lot of times people come into the emergency department and they had an accidental overdose. They had too much fentanyl. And how many of those were really intentionality because of isolation, discrimination? One study out of Glasgow a number of years ago looked at 100 people admitted to the emergency department with a variety of different overdoses from alcohol, from opiates, and 47% it was intentional behavior to die. So this is looking at suicide rates, and that are much higher in people with an opioid use disorder, which is really relevant to the really good work that's done at Caron and other treatment centers compared to the general population. So this study characterized opioid agonist treatment entrants that are being admitted for medication for opioid use disorder and treatment, who present with a history of suicidal ideations and suicide attempts, and looked at a variety of concurrent comorbid profiles. What they found in a multivariate analysis is that patients with a diagnosis or symptoms of a mood disorder were 2.48 times more likely to report suicidal ideations and 2.64 times more likely to report suicide attempts. Those with a diagnosis or symptoms of anxiety disorder were 2.41 times more likely. But if you had a history of chronic pain, you were 2.59 times more likely to report suicidal ideation. So again, it's this crossover of dealing with a substance use disorder, dealing with a chronic pain disorder, and all the psychiatric comorbidities that accompany both of these conditions. So this is a study we just completed. We just published this in 2023. So this comes from an R01 study we looked at about 5 to 6 years ago. I think we did some recruitment at Caron, and we're trying to find the mythical genetic marker of opioid use disorder in patients with pain. So we enrolled patients that they all started with no history of substance abuse except for nicotine, and that'll be relevant in a minute. And they developed chronic pain. They were all exposed to chronic opioid therapy, and one group went on to develop an opioid use disorder, and another one did not. So we're comparing apples to apples. They all started with pain. They all got exposed to opiates. One group developed the OUD in the cases, and the other one did not develop it. So we're looking at risk of suicidal ideation measured on what's called the SBQR. And with the covariates like demographics, pain severity, psychiatric history, pain coping, social support. Of the 609 subjects, 18% were at high risk for suicide. And of those at high risk, almost 52% were ones that had pain and co-occurring OUD, as compared to 23% in the low risk group. So if you look at this is look at odds ratios. But if you had chronic pain and opioid use disorder, your risk of suicide was 3.44, which is pretty high. Followed, and even a little bit higher was depression, which is typically, coexisting with chronic pain. So what about alcohol use? I've been really pushing people to get out of the opioid crisis mentality. Pain patients abuse alcohol far more than opioids. They abuse nicotine far more than opiates. And we've kind of been so focused on the opioid issue that we don't, and a lot of institutions don't even assess for an alcohol use disorder. So look at some of this data. So pain interference prospectively predicted the development of an alcohol use disorder. Decreases in alcohol consumption were associated with reductions in rating of acute pain severity 3 years later. Acute pain severity or frequency, days with pain, was associated with the diagnosis of an alcohol use disorder. Individuals with chronic pain tend to report higher levels of alcohol use and alcohol use disorder than the general population, and also report using alcohol to medicate their acute pain symptoms and their psychological pain, which is very common. 1/3 to more than 1/2 of individuals seeking treatment for alcohol use disorder report chronic recurrent pain. This is a good take-home message when you're working with folks who come in with an alcohol use disorder. Drill down a little bit about whether there's a chronic pain comorbidity, because that's going to be complicating their recovery and treatment. So let's look at risk factors and mediators. So we're going to look at sleep, pain intensity, pain duration is not relevant, pain type, and opioid prescribing. So sleep is low-hanging fruit when we treat people with chronic pain and substance use disorders. About 60 to 80% of patients with chronic pain have a very moderate to severe insomnia, and I would say that that's pretty high in patients who have a substance use disorder. So this looked at a study looking at a group of 221,000 veterans that were starting pain care. They were put into 4 different buckets: no mild pain plus no insomnia, no mild pain plus insomnia, moderate to severe pain plus no insomnia, and moderate to severe pain plus insomnia. And what they found was that the ones that had both moderate to severe pain and insomnia were much more likely to have a history of suicide attempts and are at greater risk of suicidal ideation relative to those with only insomnia or low pain. So part of suicide prevention in this vulnerable population is treating their sleep disorders. And, again, there's a variety of different interventions. We'll talk about these interventions, cognitive behavioral therapy for insomnia, being on the right medication. So this is something that has to be really important. So what happens when people are not getting good restorative sleep? 3 things happen. 1, it releases a chemical in your body called interleukin-6, which is a pro-inflammatory cytokine. So it causes an inflammatory response, which is going to increase any pain disorder that it has an inflammatory process. 2, it literally lowers your pain tolerance. So if you take a volunteer and you put their arm in a bucket of ice cold water, the cold pressor test, and they can hold it for 30 seconds, that's their pain tolerance. You sleep deprive them, bring them back in the lab, put their arm in the bucket of ice cold water, and it goes to 15 seconds. And third, and if I was live, I'd ask if anyone had been sleep deprived recently, is that when they're not sleeping, it affects their mental health, more depression, more anxiety, more frustration. So again, this can feed into the pain, can feed into the psychological pain, can feed into the depression, and can increase the risk of suicide. What about opioid dosing? Mark Ilgen's a colleague at the University of Michigan, and he looked at this retrospective data analysis and the risk of suicide by different opioid doses in the Veterans Association with Chronic Pain. So they controlled for demographic, other clinical features like depression, PTSD. And they found that the higher the opioid dose were associated with increased risk of suicide mortality. So you can look at the bottom, the harms ratio went up from every dosing, went from 20 to 50 morphine equivalent daily doses. And as the dose went up, the harms ratio of suicide went up. Now, that's a complicated finding because are they on higher doses of opiates because their pain is more poorly controlled? Because we know that pain intensity is a risk factor for suicide. Are they having more depression because their pain is higher and that's why they're on a higher dose? So it's not always a clear picture of higher dosing being at risk, but it also gives them an opportunity because they have a means of suicide with the dosing of opiates. This is another looking at opioid prescribing and suicide risk in the United States, and this is from 2023. So this looked at estimates of associations of regional changes in opioid prescribing and total suicide deaths and suicide overdose deaths involving opiates. So they looked at large kind of databases, this IQVIA longitudinal prescription database, National Center for Health Studies. They had a sample about 886. So because of the opioid crisis, the trend has been to actually stop prescribing opiates for non-cancer pain or dramatically decrease it. So they were looking at sort of these regional changes in opioid prescribing and the relationship with suicide. What they found was that suicide deaths were significantly positively associated with opioid prescriptions per capita, having any opioid prescription, having high dose prescriptions, and having long-term prescriptions, and having more opioid prescribers. So overall, they really felt the results kind of reinforced that regional decreases in opioid prescriptions were consistently associated with declines in total suicide deaths. Again, very complicated data to kind of unpack, but there is this kind of need to really look at these opioid, prescribing habits. This is a recent one also from 2022. This was looking at dose reduction. There's been a big effort, like in the Veterans Administration, to reduce all opioid prescribing, no matter what the circumstances. So this was a retrospective cohort study examined if rapid dose reduction after high dose long-term opiate was associated with suicide, overdose, or other opioid-related adverse effects. So they had a big database of 15,000 high dose long-term opioid therapy patients, and they were put into 4 different stratified buckets. Abruptly discontinued the opioid prescriptions, were cutting you off. That's about 28%. Reduced opioid dose before discontinuing, had a dose reduction but never discontinued, and had a stable or increasing dose. And what they found is that discontinuation, whether abrupt, or with dose reduction, significantly increased the risk of suicide compared with those with a stable or increasing dose. But contrast, discontinue or dose reduction reduced the risk of overdose compared to those with a stable dose. So I think they had less of the opportunity, the means for suicide, but patients with an abrupt discontinuation were more likely to overdose on heroin and not prescription opiates. And these are people that did not have an opioid use disorder. So when they were rapidly cut off, they probably had withdrawals, they had more pain, and they said, I'm going to find a way to relieve my pain. Authors concluded that these patients on long-term opioids should be carefully assessed when reducing their opiates. One study in the VA showed that this opioid discontinuation led to a 9% increase in completed suicide. So think about that 1% is our national average, 9% is significant. Another thing is vulnerable pain populations. There are some pain populations which are much more vulnerable to suicide than other ones. So this is a study looking at comparing patients with fibromyalgia, low back pain, and non-pain controls. And if you've had any experience with folks with fibromyalgia, it's a very difficult pain condition to actually treat. It's this whole body pain. It's central sensitization disorder. Most of the patients are women. They're treated oftentimes like they're hysterical. There's no biomarker of it. There's no X-ray or blood test that does it. So by the time I see these people, they're pretty beat up by the healthcare system. So they looked at suicidal ideation with these 3 groups, and they found the control group was about 5% had suicidal thoughts. Low back pain was about 18%, but fibromyalgia was up to 40%. Again, lack of validation, not treating these people as if they had a real condition. Again, marginalizing them, discriminating against them. Now, anyone knows odds ratios. People publish studies on odds ratios if you have like 1.4. If you look at this, fibromyalgia, the odds ratio for having suicidal ideation was 26. Low back pain was 4.5. The actual risk of suicide, an odds ratio of 48 in fibromyalgia patients and 4.7 in low back pain. So these patients are particularly vulnerable to death by suicide, or at least having that suicidal ideation, again, because of the discrimination, the isolation, you feeling like they're a burden on people, not believed, not validated. Complex regional pain syndrome is an extremely painful neuropathically mediated condition, which typically has significant restriction in function, so low activities of daily living, refractory to most interventions, and is very commonly associated with depression, hopelessness, and anxiety. If you look at the figure of the foot, this is someone with advanced complex regional pain syndrome, a lot of swelling, color changes, temperature changes, and they're very refractory to most treatment we have for the condition. So this is a cohort of over 250 patients with complex regional pain syndrome. And the results revealed that 92% of the patients endorsed having sleep disorders, and 80% had suicidal ideation and noted severe restrictions in activities of daily living. Again, a very vulnerable population, very refractory to treatment. What about headaches? This is a retrospective review of over 2 million, almost 3 million non-psychiatric adult clinical encounters at a large hospital. They used the Columbia Suicide Severity Scale, which was universally implemented. So the Columbia Scale assesses specific components of suicidality, wish to be dead, suicidal ideation, method, intent, plan, and action. What they found is that there were significant positive associations between presenting with a headache and two specific components of suicidality. Again, suicidality is very complex. A wish to be dead and suicidal action, plans, thoughts. Patients with tension headaches had a lower risk of wishing to be dead compared to those with migraine and cluster headaches. So patients with poorly controlled headaches are especially refractory. Migraines and cluster headaches are called the suicide headaches, should be monitored closely. And there are some new interventions for migraines like CGRP inhibitors. So there's some movement to help these patients. But when you see these patients, always be thinking in the back of your mind how much risk there are for suicide. So let's look at possible mediators. We're going to look at 4: catastrophizing, burdensomeness, social isolation, and mental defeat. So catastrophizing is very common with patients with pain, and that is basically that the pain is overwhelming them. The pain has more credence in their life, more control of their life than they want. So this is, again, looking at a study from our lab. We had almost 500 patients with chronic non-cancer pain. They were assessed for pain coping, suicidal ideation, depression, social support, and pain interference, and we followed them for 12 months. Catastrophizing was a significant predictor of increased subsequent suicidal ideation and behavior. Hoping, praying did not really protect them. It's not protective of suicide. And the relationship between catastrophizing and future suicidal ideation was mediated by depression. So this is just one example of this one factor that is very common in pain patients, catastrophizing as a really critical target for therapy. This is a study done by Kathy Kranzler, and she looked at 113 patients referred for pain-related complaints to a clinical psychology clinic. And they looked at the pain scores, and this is a multidimensional pain questionnaire. They had one question about burdensomeness. It would be better for everyone involved if I were to die. The results revealed that one question, which was perceived burdensomeness, was the sole significant predictor of suicidal ideation, above depression, above other psychiatric comorbidities. In another study from our lab from a few years ago, we looked at about 466 patients that were beginning a behaviorally based pain program. 26% had revealed a rate of suicidal ideation. Logistic regression revealed that the history of sexual physical abuse, family history of depression, and being socially withdrawn were predictive of suicidal ideation. So burdensomeness, being socially withdrawn. This kind of fits with Joiner's interpersonal theory of suicide, that suicide is a combination of thwarted belongingness, I am alone, and perceived burdensomeness, I am a burden. Think about the folks you see that have substance use disorders. They've burned through 4 or 5 different treatment programs. They've burned through their family's money. They feel like they're a burden on everyone around them. They feel isolated and alone. And that's where I think the patients that have both chronic pain and a substance use disorder is kind of a double whammy in terms of this. A lot of patients with pain They can't go back to work. They lose their family roles, their community roles, their church roles, and they are feeling more isolated and more like a burdensome. So I think when people have both pain and a substance use disorder, it puts them at incredible risk for death by suicide. Lethality is when patient feels that the pain, they're sort of numb to pain, both psychological and physical pain. Like patients that come in and say, "Oh, I want to kill myself." I'm less worried about that. I'm more worried about a patient comes in very calm, says things are fine, everything's fine, everything's fine. They're almost like blunted, emotions. I find that those are the higher risk because they kind of cross that threshold from ideation to actual plans and intent. This is another study that's in preparation. We're looking at these two cohorts. These are patients with all had chronic pain, but with a long-term opioid therapy, either developed the OUD or didn't. We looked at risk of suicide based on the SBQR. That was our assessment. We looked at covariates, including demographics, pain severity, psychiatric history, pain coping, and social support. And what we found in an adjusted mediation model that depression was obviously highly correlated with suicide risk, but that was mediated by actual what's called a DSSI, which is the Duke Social Support Index, that social support kind of mediated this depression to suicide. And if you add OUD in here, that both social support and having an opioid use disorder were mediators between depression and suicidal risk. So it sort of supports the importance of promoting social support in patients with pain and OUD. How effective 12-step programs are, because you have this social support, you have this network around the patient. That's going to mitigate the risk of suicide with these patients because they have that network and support. So when I see patients and they're isolated, I'm very, very aggressive in saying you need to go to AA, NA, OA, whatever it may be, join communities, to be involved and get that support because it is protective of suicide. This is an interesting one, mental defeat, which is developed by Nicole Tang in the UK. And it really is different than catastrophizing. It's a concept to characterize the deeper impact of pain on self-concept. It's a state of mind marked by a sense of loss of autonomy, agency, human integrity. It's a type of self-processing where persistent pain results in negative beliefs about themselves. So pain catastrophizing is the pain is overwhelming me. Mental defeat is the pain has defeated me as a person. So there'll be comments that patients will say, like, I'm defeat of the mind. The pain is taking over and you can no longer cope with what you're supposed to do. I just felt everything had beaten me and there's nothing I could do. I couldn't fight anymore. The pain belittles you as a person. It's like you're not human anymore. So very different kind of construct from catastrophizing. It's about lack of self-efficacy, self-autonomy. They kind of lost themselves. I call it being stuck. They're stuck in the present and the past and cannot see forward. And you can see how that can be a strong, predictor of suicidal ideation. So Dr. Tang did a study looking at 62 patients with chronic pain. Up to 12% had one suicide attempt, 9% two or more. And they looked at the Beck scale of suicidal ideation to measure intent. Then they looked at depression, anxiety, hopelessness, self-efficacy, and this mental defeat. And what they found was that mental defeat, depression, and anxiety were the best predictors of suicide. So these people feel like they have no self-autonomy, no efficacy, that they can't control their life, they can't move forward. So let's kind of shift to risk assessment and intervention. So risk assessment is really important. So mental health screening, pain catastrophizing, sleep disturbance, suicide risk, and again, substance use disorder, OUD screening. So there's a variety of mental health screening tools. Most people use the PHQ-9, which kind of maps on the DSM-4 criteria for major depressive disorder. I tend to use with medical patients the Beck Depression Inventory Fast Screen for medical patients because it takes out the somatic symptoms of depression. So it's much more of an accurate kind of assessment and metric for depression in patients with pain. This is a pain catastrophizing scale. There's a shorter version out now by Mark Sullivan. Again, 13 questions. It's a predictor of poor outcome from surgery. It's a predictor of suicidal ideation with these patients. And this is the marker. The pain self-perception scale is what's developed to really measure mental defeat in these patients. Again, very simple kind of assessment model. There's a variety of sleep assessment scales. Pittsburgh sleep quality is used a lot in research, but it gives you a really good kind of marker of sleep quality in these patients. And again, we're trying to target these risk factors to mitigate them, to reduce the risk of suicide, but also the risk of suffering. So in the opioid abuse and substance use screening tools, the top three, the opioid risk tool, the screener and opioid assessment for patients with pain, and the DIAR, diagnosed intractability risk. These are all assessing patients that you're considering to start them on an opioid therapy, long-term opioid therapy, but it doesn't really assess risk of developing an opioid use disorder. It assesses the risk of developing aberrant drug-related behaviors, which may or may not be indicators of an opioid use disorder. The next three are all ones that are developed to look at people who are on long-term opiates to see if they're developing these aberrant behaviors. And you're probably all familiar with the ones not specific to pain populations, like the CAGE-A, RAF, DAS, the SBIRT, and the AUDIT-C. So if we look at the opioid risk tool, this was developed by Lynn Webster, who's a pain anesthesiologist, and it wasn't really psychometrically developed. It was more based on what he felt was indications of it. So some of these are very, very specific to developing any type of substance use disorder, like family history, you picked your parents poorly, alcohol, illegal drugs, prescription drugs, personal history of substance abuse, age. This is the one that was kind of confusing, which was the history of pre-adolescent sexual abuse, but you only mark it if you're a female and not a male, which made no sense, because and most people in the area field know that one of the biggest risk factors for developing a substance use disorder is adverse childhood events. Doesn't matter what your gender is or what the type of abuse was. So that didn't really make sense to me. And then psychological diseases. So we published this article a couple of years ago using the same population, patients who developed chronic pain, and they subsequently developed an opioid use disorder or not, apples to apples. So we did a revised unweighted ORT, removing the history of pre-adolescent sexual abuse because it didn't make sense. And then we removed the actual weighting, because the weighting he did was, again, just kind of spitballing, like, 3, 4 versus 5. It had no really bearing in the science. So what we found is that the original ORT, and again, this is we're comparing people who actually develop an opioid use disorder, not just aberrant drug-related behaviors. So it wasn't bad. It predicted, had an odds ratio of about 1.6 in predicting development of OUD in patients with pain. And then we looked at the one that was weighted without the sexual abuse, again, about 1.6, not bad. But our new ORT, where we took out the weighting and the sexual abuse one, went up to 3. So it's the only tool that actually predicts the only tool that actually can assess the risk of developing opioid use disorder in patients with pain starting opiates. Another study we did looked at smoking. So again, same kind of cases were the ones that had pain and OUD, and the controls were pain without OUD. So 80% of cases reported tobacco. And anybody who walks outside of a methadone treatment clinic or any treatment facility, the smoking is rampant, right? And about 22% of the control smoked. We asked one question: have you had a cigarette, one cigarette, the last 7 days? That's the only thing we asked. Controlling for all other known risk factors for substance use disorder, we found that one question was strongly associated with the development of opioid use disorder. And the odds ratios, no matter how you did the statistical analysis, went from a low of 5 to a high of 15, which makes sense because the nicotine kind of sensitizes the dopaminergic system so that they're already kind of set for an addiction. So suicide assessment tools, there's a bunch of different ones. The Columbia is kind of the gold standard when you're developing new drugs or doing research. I, again, tend to use the suicide behavior questionnaire because it's quick and easy and well validated. Beck scale for suicidal ideation. So there's some really simple ones that are pretty easy to use. So once you've done your risk assessment, now it's stratification. Low versus high risk. Plans, vague versus specific. Means, no versus yes. Lethal supply of opiates, antidepressants, alcohol. It's interesting being in Ireland is that most of the suicides are by hanging drowning, or alcohol. Where in the United States, it's guns, and because Ireland doesn't have guns. It's really interesting to kind of how what they choose. Past history of suicide attempts, the best predictor of future behavior is past behavior. Level of support, again, that mitigation of support. Coping abilities. Do they have a good relation with their healthcare provider and willingness to contract? So you're kind of getting people in this low to high risk. So acute suicidal phase, again, inpatient treatment, depending on the severity, pharmacotherapy, targeting depression and sleep. Stopping their opiates is probably not a good idea, as I've sort of indicated previously, that you may actually push them over the edge, but small amounts, family members dispense it, frequent urine drug tests to ensure adherence. And then there's chronic depression, requiring ongoing psychiatric care, frequent urine drug tests if opiates are prescribed, regular mental health screening. I have a patient who was religious, had a strong religious background, and she would never take the steps to die by suicide, but she lost her husband, was profoundly depressed. She basically became anorectic at age 60. So she was just starving herself to death, which is kind of a chronic suicider. So let's look at the non-pharmacologic and pharmacologic. So the non-pharmacologic therapy for pain and substance use disorder, we have cognitive behavioral therapy, acceptance commitment therapy, exercise, and social support. Most people are probably familiar with cognitive behavioral therapy. It focuses on two types of maladaptive thinking and behavior in pain patients. So it's thinking, catastrophizing, and behaviors, kinesiophobia, fear of movement. It is very frequent. So people don't move, they get weaker, they have more pain, more catastrophizing, more depression, more despair. The whole objective of cognitive behavioral therapy is to guide the patient in recognizing and reconceptualizing her personal view of pain, identifying their role in the process of healing, promoting them to be not reactive, but proactive, and competent rather than incompetent. These people come in with low self-efficacy, so it's building up their confidence. So it's specific skill acquisition, relaxation therapy, stress management, mindfulness-based stress reduction, cognitive restructuring, followed by skill consolidation, rehearsal, and relapse training. It's been shown repeatedly with Cochrane reviews that cognitive behavioral therapy is extremely effective in targeting two things, which I think are really the target of pain management, is function and mood across a variety of different pain disorders. Cognitive therapy for insomnia has been demonstrated to be equally effective or even superior to pharmacotherapy in patients with chronic pain. And that's a very simple program. I mean, it's about sleep hygiene. It's about teaching relaxation therapy, reducing stimulus before you can get these people to change these behaviors. Not only are you improving their sleep, you're giving them self-efficacy. I don't need a pill to do this. I can do this and change my behavior. They start building momentum. They start breaking the cycle of despair. And acceptance commitment therapy, which I think has been extremely, very, very effective with people with pain, is a very directive and experiential type of therapy based on rational frame theory. The whole goal is to sort of experience life mindfully, but what you want to do is psychological flexibility. It's finding ways around your pain, whether it's emotional or physical pain or substance use disorder. Finding ways around. I tell patients it's a lot of metaphors with ACT. You want to dance with life, not wrestle with life, right? And there's really 6 components. It's contact with the present moment, self as context, diffusion, acceptance, values, and committed action. And what I love about ACT they basically feel that all the psychiatric diagnoses like major depressive disorder, generalized anxiety disorder, et cetera, are all arbitrary. And that when you're a pain person and you wanted to garden, but you can't because you have a pain flare and you're angry and disappointed. In the ACT model that's human, that's normal. Don't push it down because it will eventually bite you. Experience it, live with it, right? But it's very values-based. Like, what do I value in my life? That's your GPS in life. Lots of randomized controlled trials in the use of ACT and chronic pain have shown tremendous effectiveness in promoting mood and function improvement. So if you look at the literature, there's tons of literature that's been evolving, looking at both CBT and ACT for pain and substance use disorders. So this has been a big wave. So if you look at some of the literatures coming out, this is an evaluation of preliminary efficacy of a CBT therapy for opioid use disorder and chronic pain by Declan Berry up in Yale. It's another one to look at, again, training in opioid tapering. Other ones looking at a mindfulness-oriented recovery enhancement for both methadone treatment for people with pain and opioid use disorder. So it really has become really in the focus is to kind of the integration of cognitive behavioral therapy and acceptance commitment therapy, targeting both improving pain and coping and OUD. What about exercise? Exercise is really important in any type of behavioral program for pain and substance use disorders. It enhances the release of endogenous opiates, reducing the use of prescription opiates, which can also reduce mortality and morbidity. Lots of studies have shown that aerobic exercise significantly improves function and quality of life. If I was there, I'd ask if anyone was a runner. And when I ask people, do you run, what you run, I say, why do you run? They usually don't say because it's cardiovascular health. It's about, it makes me feel calmer, right? I feel calmer. So exercise is a potent anxiolytic, anti-anxiety agent. It blunts the body's response to cortisol, increases brain serotonin levels. So getting people to move is going to help their pain. It's going to help their anxiety. It's going to reduce their liability for depression, anxiety, suicide. Pharmacotherapy should really focus on sleep, pain, mood, and substance use disorder. We're going to really look at substance use disorder and pain and kind of the intersection of the two. So we're going to, there's really 4 different types of medications that we're going to focus on: methadone, buprenorphine, extended release oral naltrexone, and ketamine. Again, this is the pain, suicide, OUD interface. So buprenorphine, as you probably know, is a partial agonist of the mu opioid receptor and antagonist of the kappa receptor. It was an anesthetic back in the 1980s, and then they found that it was really helpful in both producing analgesic effects, but it also, at the kappa receptor, rendered them inactive. So this is looking at 51 suicidal male inpatients who fulfilled DSM criteria for both opioid use disorder and major depressive disorder. And they received a single sublingual dose of buprenorphine, 32, 64, 96. They completed a 3-day trial, and the outcomes it illustrated a significant reduction in suicidal ideation based on the Beck score within each of the groups, and dosing didn't matter. So this single dose caused a significant decrease in suicidal ideation, and they think it's the interaction between the mu and the kappa receptor. So when someone has pain, has OUD, and has suicidal risk, this is a molecule that can really be very effective in targeting all 3 of those components. This is also another one looking at ultra dose of buprenorphine. These were people that were severely suicidal without any substance abuse, and they received either buprenorphine or placebo in a 2-to-1 ratio. And again, they received this ultra dose buprenorphine, and they found a dramatic decrease in suicidal ideation compared to placebo, even up to 2 weeks. Even up to 2 weeks, and you can see the difference here. So buprenorphine is a molecule that has some real potential to target all of these different factors in patients that have pain and a substance use disorder. What's been really kind of very pushed lately is ketamine. And ketamine is a non-opioid anesthetic that's used perioperatively, but also has been used more and more for treating post-traumatic stress disorder, depression, and certain complex regional pain syndromes, neuropathically mediated pain. So this was a systematic review and individual participant data meta-analysis examining the effects of a single dose of ketamine on suicide. So they looked at all these different studies, and they looked at both clinician-administered depression ratings and also self-reported scales on depression and anxiety. And they found that ketamine rapidly reduced in 1 day suicidal ideation on both clinician-administered and self-reported outcome. And you can see the difference, the division between these placebo versus ketamine. Again, so possibly ketamine could be a very effective intervention for people who have pain and substance use disorder and suicidal risk. Now, I have to say that ketamine is not a benign drug. There's lots of complications with ketamine, so it needs a lot more research. And I'm going to skip this one for time's sake. Naltrexone, again, been around for a long time. It's been approved for alcohol use disorder, opioid use disorder, alcohol-dependent adults. Extended release naltrexone increased initial and 6-month abstinence. And OUD following detoxification showed efficacy in abstinence, improving retention, etc. very feasible in primary care public systems. There's evolving evidence that low dose, like very, very low dose of oral naltrexone is effective in reducing pain in patients with central pain syndromes. So we have to, again, a lot more research on the dosing and how naltrexone can target both, the pain syndrome and substance use disorders. Here's the newest one, psilocybin. Yeah, I'm working with a colleague who's an addiction psychiatrist at NYU looking at psilocybin and pain and suicide. Tons of new literature coming out looking at psilocybin assisted therapy for alcohol use disorder. This just came out, was very effective in combining psychotherapy with psilocybin and alcohol use disorder. Another one looked at alcohol seeking by disruption, the reconsolidation of alcohol related memories, those cues that we're always talking about in addiction therapy. There's a heavy drinking days following psilocybin assisted psychotherapy versus placebo. There's also ones looking at psychotherapy in the treatment of methamphetamine use disorder and psilocybin. Then another one looking at resistant depression, with psychedelics. And lastly, there's some ones looking at select pain conditions. So again, I think that these are all interesting new molecules that need a lot more work, but they have some real potential. So my take-home message is suicidal ideation is highly prevalent in patients with chronic pain and patients with substance use disorder. If you have both pain and substance use disorder, particularly vulnerable to the risk of death by suicide. Possible mediators of the relationship between pain, substance use disorder, and suicide include a sense of burdensomeness, mental defeat, social isolation, poor stress coping abilities, in particular catastrophizing. There are risk factors that we can modify, we can mitigate, getting their sleep better, improving their pain intensity, their pain coping, really kind of supporting them, getting social support, and treating the comorbid substance use disorder. And globally, poor access to mental health services needs to be addressed. At Penn Medicine, to get in to see a social worker for general psychotherapy is a 9-month waiting list. So we've kind of, ignored, people talk a lot about, this, opioid crisis and the gun crisis, but we don't fund enough with global mental health and substance use disorders. Some future directions, we need to test delivery systems for CBT and ACT. I think COVID has kind of, pushed us into looking at, alternatives to one-on-one psychotherapy because there's not enough of us. We need to look at phenotypic and genotypic characteristics of suicidal ideation and behavior with patients with pain. There's some genetic work on serotonergic, markers for suicide. We need to explore the potential efficacy of buprenorphine, ketamine, these other novel pharmacologic agents, but they're not safe agents. So we need a lot more research on the ketamine and buprenorphine and psilocybin. What people may be helped by it, what my people may be pushed over the edge in terms of their recovery. These are all the people that make me look better than I am, and thank you for your attention. And I finished with 1 minute, Aaron.
Thank you, Dr. Cheatle, for that very interesting presentation. And the intersection of all of those just really is fascinating. We do have one question. I'll tackle that one right off the bat. So, is there a difference of suicidal ideation percentages for persons utilizing the Sublocade shot versus the buprenorphine films or tablets?
Interesting you would ask that question. Is that someone, for Dr. Denick, did you put that in for me? So we're actually, Dr. Campman and we just submitted a grant to the NIH looking at patients that are on sublingual buprenorphine, and we're going to transition them to Sublocade and look at their pain control and their depression. Feeling that there's less trough and valleys with the Sublocades, and no one's really proved that. There's one study out of Australia that showed that Sublocade was very effective in. The study was looking at feasibility and acceptability, but it really found that it improved depression and pain. It was kind of a single-arm study. So that's a great question. So we actually are just in the process of submitting that grant today.
That was good timing.
That's why I think it was a setup question from you, Dr. Denick.
Questions from the audience? Yes.
Give me 1 second. Hold on, I'm gonna grab you a microphone.
The question is, can you say more about naltrexone and its impact?
Well, naltrexone, as you know, is, I think, extremely effective for OUD and AUD. It really doesn't have a pain relieving effect that you would get with buprenorphine, for example, or ketamine. And again, there's just one or two studies that really microdosing oral naltrexone, we're talking about 4 or 5 milligrams, have been really effective in some cases with fibromyalgia and central pain syndromes, like from a stroke. But at such a low dose, you wouldn't have much of an effect in terms of sobriety and recovery from AUD or OUD. So that's where I think naltrexone is kind of in that gray area. Low dose is not going to help their recovery, and it might help their pain. And ketamine's one that they're really pushing this, and there's ketamine clinics everywhere for PTSD, and they need a lot more research because, again, it can be a very dangerous drug. There's renal problems, cardiac problems. So I think they all have some potential, but I really think that buprenorphine, in terms of these patients that have opioid use disorder, pain, and depression, I think it can be extremely effective in kind of mitigating some of these risks and helping their recovery and their pain.
Yes. Hang on, we got a mic. Hi, can you just speak a little bit about any real research regarding THC or cannabis and pain?
It's a tough one. I because I wear two hats, pain and also substance use disorders. And it's funny, in Pennsylvania, you can get certified for medical marijuana if you have a pulse. So they'll say you get, no, seriously, they say it's good for autism, it's good for PTSD. There's no literature on that. There is some fairly strong literature on cannabis being a certain CBT, for example, being helpful for chronic pain. We have a study we're doing at NYU looking at just strictly CBD for lumbar pain with some results. But again, that it also can trigger relapse, right? I mean, we don't know that enough. So my fear is, in the pain center, we're giving everybody medical marijuana, right? That's what we did with opiates. Everybody gets opiates because it's the right thing to do. So if you look at the statistics of all the patients who receive opiates that are chronic pain, that don't have a history of substance abuse, 10% go on to develop an opioid use disorder. 10% of people have alcohol use disorder. 10% have cocaine. So there's going to be 10% of these people that we give cannabis to who are going to develop a cannabis use disorder. And people will argue, well, they can't overdose from it. But there's literature that say they do transition to more dangerous drugs. So again, I think it's this panacea that we're going to give everybody CBD. There's going to be 10% of those people that we're going to put down that rabbit hole of addiction. I don't know if I answered your question, but yes, there is some literature, but I think we're not being really judicious in how we're managing this and doing this.
I did have a client one time who used CBD ointment for complex regional pain syndrome, who found it helpful.
Yeah,
that's a case study of one. So
well, that's topical, that's systemic, right? So I mean,
right.
But
right.
I mean, it's just 10% of people that we're just throwing this cannabis at they're going to develop problems. Any other questions? I think there was one in the chat.
Any other questions? There's supposedly one in the chat, so let's see.
This is a good one. This is in an inpatient setting, specifically for a methadone program. How do we navigate a balance with social supports needs for patients who maintain a take-home medication status? Well, again, I encourage people to work the program. Make sure that they can still get after hours, NA, AA, or even like if they have, church groups. I mean, I have patients where I just say, I'm not going to treat you unless you get off the couch and don't isolate yourself. So I think we're going to have to use those other resources like AA and NA that have been around a long time and get them to make that commitment. Is there a difference of suicidal ideation percentage in persons utilized? Okay, we did the Sublocade.
I have a question for you, just because we see, a lot of people come to treatment who they come in with an overdose and they have overdosed on an opiate and they end up in treatment. From what I'm hearing and from what you're talking about, it sounds like the screening for individuals who overdose, who land in treatment, should be a fairly thorough suicide screening, that it isn't just always accidental. I think a lot of times we think about the potency of the opiates out there leading to overdose and maybe don't necessarily dive as deep into the intent. I'm not speaking for clinicians in general. I'm just kind of hypothesizing that maybe we don't do it as in depth of a suicide screen because we think about, oh, it's an overdose due to the potency out there.
Well, it's a great point. And again, sometimes one of my many failed grants that never got funded was to actually look at people who come into the emergency department with an overdose and really doing sort of a mixed methods, both qualitative, quantitative, like was there intentionality there? So I think we just assume, oh, you got too much fentanyl in your heroin or, and you made a mistake. But I think that if you look at these if I've convinced you of anything, people who suffer from a substance use disorder suffer. That embarrassment, that isolation they have, the feeling like a burden to everybody. How many people have you seen a Karen this is their third round? This is their fourth round, and they're defeated. So to say that a certain subgroup of those folks aren't going to have, suicidal thoughts and kind of ignoring that, I think that's a great point. I mean, people don't usually feel uncomfortable with suicide, but I think it's something we should put on the table, and it's okay to feel this way. And why wouldn't you feel this way? But let's do something about it. Let's mitigate some of this. And some of this we can't. I mean, I mean, being overseas for 3 months and there's pros and cons to it, but, safe injection sites, there's more of them in Ireland than there is in the whole United States. There means certain things that we can do to really help people and we just don't. That's my soapbox. That's my soapbox.
Thank you. The other question I would ask is, I was struck by the burdensomeness slide, and then I got to thinking of older adults with SUD and chronic pain. From a suicide perspective, what is the prevalence of suicide in older adults with that combination?
Tends to be higher than, in older adults. I think there's not a lot of data by age, but just my sort of anecdotal of working with patients that, again, you get older and you feel like, you're, again, with the mental defeat, you never look forward, right? You're looking at the present and the past, my failures. I can never get better, and I think that so as you get older and you have more health problems on top of the chronic pain, plus maybe some of the health problems because of your substance use disorder, I think there's a higher prevalence of sort of depression and sort of feeling defeated by all of it.
Any last questions? Going once, going twice? Okay, thank you so much, Dr. Cheatle. When you get back to the US, let's do lunch, please. It's been way too long.
I'm not coming back, Aaron.
Oh, okay. Well, all right.
Dr. Denicky,
I'm going to request Karen to send me to Ireland so I can do lunch with you. How about
Dr.
that?
Denicky, you can come visit me in Ireland all you want.
Okay. All right.
Thank you so much. Thank you so much for inviting me. It's a pleasure.
Okay, we are going to take another 10-minute break and resume promptly at 11:20. Again, everybody has to be back in their seats at 11:20 so we can get. Oh, yes. I just had a note that we will be sending the recordings and the PowerPoints out in, I think, approximately 25 days after this presentation. Thank you. Hey, how are you? Good to see you.